Welcome to our podcast, Fear of Fentanyl, Fact or Fiction, where we discuss fentanyl's history, its medical applicability, how it works in our body, and why it's relevant to discuss today.
Advancements in medical research throughout history have led to the development of synthetic opiates called opioids. The reason for their creation varies from problems with quantity or attaining the original opiate, or for overcoming their limitations, leading to the creation of drugs with higher efficacy or more effective anesthetic properties. Fentanyl is an opioid that fits within this conceptualization and has garnered lots of attention as of late, partly because of its infamous addictive potential and high potency leading to overdoses.
In North America, there's a widespread opioid crisis, with fentanyl being the culprit for a substantial portion of overdoses, with 85% of opioid-related deaths in Canada related to fentanyl. Research to remedy this problem is important since it affects so many people. In Peterborough alone, 10 people die from an opioid overdose every month according to 2021 statistics, which show a steady rise in opioid overdoses over the last 5 years.
Understanding how opioids affect our body is the first step to developing more effective means of dealing with this social problem. Finally, acknowledging how individuals are influenced, both by situational factors as well as information available to them, like education and media, impacting their choices regarding fentanyl use.
There's no question that fentanyl is a dangerous drug, somewhat misreported or misrepresented in the news. But there's no such thing as a good or bad drug, and this becomes shockingly evident when we look at fentanyl's history. The history of fentanyl starts in Belgium during the late 1950s with a pharmacist named Dr. Paul Janssen, the founder of Janssen Pharmaceuticals and a structure-activity pharmacologist and medical doctor. He was interested in treating pain syndromes that were receiving inadequate attention via analgesics. Dr. Janssen soon started experimenting with meperidine, an opioid with a simple structure but lacking in potency. Over the course of about 4 years, Dr. Janssen attempted to change the structure of meperidine by increasing its lipid solubility in order to increase potency and specificity. A process of trial and error in animal subjects over this period of time yielded the new molecule, fentanyl. To start spreading knowledge of the new molecule, Dr. Janssen started to give samples to clinician friends so that the drug could gain some clinical experience. The first clinician to evaluate fentanyl was named George de Castro, an anesthesiologist. He used fentanyl as a component of narcotic, hypnotic, nitrous oxide, oxygen anesthesia in combination with other inhaled drugs, and sometimes as a pure narcotic in large doses. De Castro was very impressed with the molecule, which prompted Dr. Janssen to start experimenting all around Europe, eventually leading to its approval in Western European countries around the mid-1960s. During this time, fentanyl was being used in combination with various intravenous hypnotics in a technique called neuroleptic anesthesia, a popular technique in Western countries that found its way into Europe, in which fentanyl is combined usually with large doses of droperidol. Popular in America, it wasn't until 1968 when a mixture called Inovar was approved, essentially a combination of droperidol and fentanyl.
So is there any reason that they chose to use droperidol specifically?
So droperidol was chosen because it actually had such strong negative psychological effects that it would deter drug addicts from abusing it, and that's actually what allowed its approval. However, this approval was only possible in 1963 because Janssen Pharmaceuticals was purchased by Johnson & Johnson, giving Dr. Janssen plenty of new contacts to advertise his new drug to. One of these contacts was Robert Dripps, professor and chairman of anesthesiology at University of Pennsylvania in Philadelphia. Janssen wanted Dripps to help him get fentanyl noticed by the FDA and eventually approved for use in America. However, Dripps had many concerns about the incredibly potent drug surrounding its safety and if it was actually needed. It took Janssen years of convincing before Dripps would help get the mixture approved. Inovar wasn't used much after its debut, but it was also rarely abused, and for that reason 4 years later, the Janssen company was successful in getting fentanyl approved by the FDA as a sole agent. Once fentanyl was approved for use, its most popular application was a component of nitrous oxide, opioid, oxygen anesthesia. It later garnered more attention when it replaced morphine in high-dose opioid anesthesia, usually used for open-heart surgery, for morphine consistently showed problems with its anesthetic qualities. This breakthrough led labs in Belgium to start looking at alternatives to fentanyl molecule as a pure opioid anesthetic, leading to the creation of alfentanil and sufentanil.
We've now established that fentanyl isn't all bad. It has therapeutic qualities in pain relief and anesthesia. However, it is still very dangerous, which is evident with the current opioid crisis. In an effort to control dangerous substances like fentanyl, these substances are scheduled and its uses may be restricted and monitored. The article by Whedon explains the criteria of scheduling enforced by the Canadian Standards Association, or the CSA. It consists of 5 tiers, and its placement is based on an 8-factor analysis. However, some are more influential in its scheduling fentanyl, including its actual or relative potential for abuse, its scientific evidence of its pharmacological effect if known, its history and current pattern of abuse, and what, if any, risks there is to the public health.
Fentanyl is currently a Schedule II substance in the US, but Schedule I in Canada. However, fentanyl and fentanyl analogs or fentanyl-related substances, such as all-fentanyl, sufentanil, or carfentanil, have been temporarily scheduled as Schedule I narcotics with no approved clinical use as of February 6, 2020, due to its current state of abuse. The main reason fentanyl is either considered a Schedule I or II substance depends on whether or not the country allows or sees applicability in a clinical setting, its current pattern of abuse, and how a country might interpret its abuse potential.
So, how has Canada chosen to schedule fentanyl?
Since Canada has fentanyl under Schedule I of controlled substances, we can assume they see no use for the drug clinically and have determined its abuse potential to be too high for consideration. US, on the other hand, has fentanyl placed under Schedule II of controlled substances in the past, so they must have seen some potential for the drug in a clinical setting. Concerning fentanyl's abuse potential, it is very high because it is an extremely potent opioid, similar to morphine, that you can get addicted to very easily. However, it is often abused in combination with other substances, provoking very high overdose rates. Nevertheless, it seems the U.S. has concluded that as its sole agent, fentanyl's abuse potential is controllable in the least, allowing them to place it under Schedule II. As mentioned earlier, this is no longer the case with the current opioid crisis spiraling out of control. Any type of intervention the government could enroll must be taken advantage of. Therefore, they decided to temporarily schedule fentanyl, its analogs, and FRSs as a Schedule I controlled substance, halting its use in clinical settings, monitoring its distribution, stopping production of fentanyl, FRSs, and analogs of the drug. At first glance, this all seems practical. However, there are some ramifications that come with temporarily scheduling this whole class of narcotics as Schedule I. The way Canada has scheduled this class of drugs involves scheduling focusing on chemical similarity to the structural portion or portions of the molecule responsible for the pharmacological effect of the molecule. This is the so-called pharmacophore moiety. This method allows Canada to differentiate between a drug's pharmacological activity and its chemical structure. Therefore, a drug that may work as an antagonist that reverses an opioid-related overdose but not invoke any kind of high wouldn't be included in the class-wide ban in Canada. However, during the temporary scheduling that is taking place in the U.S., no matter what the drug's pharmacological effect is, if it has a similar structure, it is included in the ban.
Another complication presented by Comer and colleagues in the article Potential Unintended Consequences of Class-Wide Drug Scheduling Based on Chemical Structure, a Cautionary Tale for Fentanyl-Related Compounds, involves interventions such as vaccines and monoclonal antibodies that are being developed in order to treat opioid and fentanyl-related disorders. The interventions put in place by temporary Schedule I scheduling could complicate any efforts in developing and distributing these interventions, potentially furthering this crisis in the long run.
With all that in mind, should we continue to use scheduling to restrict these drugs?
Scheduling has many problems with it as an intervention. However, it's not something that should be ignored or abandoned, as it is a good tool in illustrating and comparing the dangers of these various narcotics.
So where should we place fentanyl?
Well, as of this time, we believe that fentanyl does belong in Schedule I with many of its counterparts, mainly due to its high abuse potential stemming from incredible potency and rapid activation, current state of abuse, and limited and situational use in clinical settings. However, there are many molecules in this class that shouldn't suffer the same consequences.
Now that we understand where this drug came from, its clinical applicability, and its historical significance, how does it work?
Fentanyl works by binding to someone's mu-opioid receptors across your brain and body, controlling pain and emotions. Since fentanyl is an agonist, it activates the receptor, but mu receptors have both activating and inhibiting functions. It activates these euphoric effects, but also depresses breathing. According to Bechmutsky's research, two predominant locations of these mu-opioid receptors are in the hindbrain, more specifically the pre-Botzinger complex, pre-Bot-C, and the parabrachial and adjacent Kolliker fuse, the PBN/KF sites, which control respiration. These receptors inhibit around 140 glutamatergic neurons in these sites. The more fentanyl that is taken, the more depressed someone's breathing gets until they overdose and asphyxiate.
So how should we deal with overdoses?
Well, naloxone is a commonly used drug to counteract an opioid overdose. Drugs that inhibit the opioid binding process do so through an antagonistic binding action, rendering the opioid receptor inert and leaving the breathing function intact.
Is naloxone very effective?
Well, synthetic opioids like fentanyl are faster acting than other opioids like heroin. A drug like naloxone doesn't always work because it's often too late to stop the effects of fentanyl. An alternative solution would be to give people a preventative to avoid overdose from fentanyl altogether. Fentanyl may be dangerous, but it shouldn't be avoided or prohibited altogether. There have been many clinical uses for the drug. Fentanyl is an effective pain reliever for high-level pain that can't be eased by other, less efficacious analgesics. This is supported by Pavelka's research, who looked at fentanyl skin patches for arthritis.
So, what is the best way to protect people from the dangers of fentanyl? Research by Rayleigh points out that individuals often overdose on fentanyl accidentally by using cross-contaminated drugs, and that an effective way to avoid the lethal effects of fentanyl is by administering a vaccine to produce antibodies that break down fentanyl before it binds to the opioid receptors. The vaccine Rayleigh looks at was derived from a fentanyl-based hapten, a molecule that releases antibodies, and a GMP-grade hemocyanin subunit, which is a molecule used for carrying oxygen. They found this vaccine, called F-SKLH, moved the dose response curve for fentanyl to the right, meaning that more fentanyl was needed for it to have an effect on the body, including toxic effects.
I've heard these antibodies mentioned a couple times. What are they, and how are they relevant?
This is relevant to our topic since Hick's work seeks to advance to human clinical trials to counteract fentanyl toxicity. Hick used specific anti-fentanyl monoclonal antibodies, which are specific antibodies developed after encountering fentanyl already and then reproduces in order to break down fentanyl in any future encounters. These findings are vital to dealing with fentanyl overdose and mortality since it binds with fentanyl and metabolizes it before it even binds to the opioid receptor. Another reason why using monoclonal antibodies is beneficial is because of their high specificity, which means they target fentanyl and any of its derivatives without targeting any other opioids in the system. Unfortunately, Hick's research has had problems with the monoclonal antibodies when humanized. They were high in hydrophobicity, which means they made them unstable and prone to aggregation, meaning they don't mix well in the environment of the body, making them unstable. These antibodies did not exclusively target fentanyl like they did in rat models, and so more work is needed for them to be used clinically.
Hick's work still contributes to the knowledge base on fentanyl and opioid functioning in general, and moves research a step closer to creating antibodies that are more effective. These antibodies could be used for individuals who are at a high risk of fentanyl overdose, such as a habitual fentanyl abuser, since it could end up saving their lives with no negative consequences.
So, will regular fentanyl users seek out this treatment?
Well, despite the fact that they'd be the group that would benefit the most from this treatment, they may not want to seek it out themselves. Having this treatment available at locations where fentanyl is frequently used, or hotspots, could further reduce overdoses. Using this preventative measure would be good for those who are still seeking to use opioids recreationally, like heroin or morphine, those who live in a high-risk environment who wish to avoid accidentally taking fentanyl, or those who use opioids to control pain for medical reasons without the risk of the drug being compromised by fentanyl. Another benefit is that monoclonal antibodies allow for other opioids to work as well as having no precipitating withdrawal symptoms, qualities that characterize naloxone.
Are there any innate risks to developing an addiction to fentanyl?
While there are no biological risks for addiction to fentanyl itself, there are genetic predispositions for developing addictions to substances in general. An addiction to opioids, or fentanyl specifically, would increase the frequency of use and increase the likelihood of overdosing, especially with the demographic of individuals who use fentanyl, generally less educated, not knowing the full mechanics of how tolerance builds and dissipates. There are also social factors that can increase the risk of fentanyl overdose, individuals with lower socioeconomic status and those using other drugs. The pandemic has exacerbated the supply of illegal opioids, making morphine more difficult to obtain and more expensive, and heroin has become more expensive as well, so individuals have turned to fentanyl as an alternative.
Many different things can cause people to seek out the use of fentanyl and other opioids. Whether it's coping, availability, or even accidental, there are many driving forces that lead people to the decision to seek out these illicit drugs. As a result, opioid use, and specifically the use of fentanyl, has increased dramatically over the last decade, despite its origins as a pain-killing drug. The article by Hahn and colleagues, The Rising Crisis of Illicit Fentanyl Use, Overdose, and Potential Therapeutic Strategies, discusses not only the increase in the abuse of fentanyl, but also the potential and previous use it had as a pharmaceutical. While potentially an incredibly useful drug, it is also dangerous, and as a result, studies like this help us gain a greater understanding as to why fentanyl is such a large issue. While it is still used in cancer treatment, fentanyl is also laced into many street drugs that, when taken unknowingly, can lead to overdoses, injuries, and even death. In fact, in 2016, illicit fentanyl use made up more than half of all opioid-related deaths in the United States. Clearly, fentanyl can be dangerous if used in the wrong ways, or if it's abused, but that's also not to say it's inherently bad.
To build off of what was said before, fentanyl acts by depressing our respiratory system. According to Hill's studies, fentanyl not only acts more effectively than other opioids, but also acts much faster and is more potent. Fentanyl even behaves differently when it comes to tolerance and cross-tolerance. They found that While there is a cross-tolerance between the other two opioids tested, morphine and heroin, this tolerance did not cross over to fentanyl. They did find that lipophilic or fat-loving antagonists, specifically buprenorphine, may be more effective than naloxone. It's interesting to think about how differently fentanyl works in regards to other opioids, and that such a widely abused drug was originally used for medicinal purposes before it became such a large issue in the West. Not only are the common methods of treating overdose less effective, but using monoclonal antibodies as a preventative does not have sufficient research, and we still aren't sure how to make them effective enough to administer them publicly. While interesting from a theoretical standpoint, in practice, it makes it a much more dangerous and efficacious drug that can be abused easier than other opioids, which may be another addition as to why its use and abuse is such a massive issue throughout the world.
Research done by Meyer and colleagues shows that fentanyl can be used to great effect in reducing post-surgery pain in patients. In their study of 50 people, they found that fentanyl, when given in safe, small doses, helped reduce post-surgery pain in the patients that were given it. Interestingly, despite how it's often shown in the media, fentanyl isn't inherently bad and can be used for the benefit of people rather than just to harm them. As a result, its use as a clinical painkiller and anesthetic does have scientific backing, but still requires more research before it can be used more widely. If found to be worth using, however, it could potentially improve the post-operative pain in many patients, as the research found it was more effective than other opioids like morphine and heroin. The nociception level index, an AI-guided method of drug dosing, was used to guide the dosage of opioids in the study, and using it helped with the perceived satisfaction of fentanyl's pain relief when compared to other opioids. Using this index not only improves the dosing of fentanyl, but also other drugs used in clinical settings, and can also contribute to helping treat post-surgery and post-operational pain in many patients. Thus, technology, like the NOL index, can be used to help manage doses of various drugs given before, during, and after surgery, and even in the other possible cases such as prescriptions.
With the opioid crisis being such a large issue in the West and in Peterborough specifically, hearing any good news about these drugs and what they do can help bring a bit of hope into what some of us may see as a hopeless situation. With it being such a large local issue, it can seem that fentanyl is only bad and has only negative effects and uses. But learning about its clinical use and history, as well as understanding why it's so dangerous when abused, can help alleviate some fear around it and bring some good news about the drug rather than being doom and gloom all the time.
Fentanyl has had a complicated history since its creation in the 1960s. While the media has portrayed it as an evil drug, and it does account for a large amount of opioid overdoses in Canada, it also has a variety of medical applications. By understanding how it binds to mu receptors and how potent and fast-acting it is compared to other opioids, we can develop a greater understanding of fentanyl's role in the opioid crisis and why it is dangerous, but also its other uses in medicinal contexts. If we can all better appreciate fentanyl and why it acts the way it does, it can not only help create a more informed public, but also potentially improve medicine and our treatment of opioid overdoses across the board.